So this is the fourth respiratory physiology lecture. This one's on ventilation perfusion or mismatch. The overall way that we'll do this, again, these are combined talks. These concepts we'll bring up in previous talks that I'll talk about now as assumed knowledge. We'll run through how the questions are answered and the type of content that they're after. We'll add some background knowledge or knowledge that you require to answer this question, and I'll try and talk about those concepts a bit further, try and develop them and some of the diagrams, and then we'll run through a model answer. The types of questions that you'll see relate mainly to a particular graph which we'll come up with, but you must understand the concepts that lead to it. The concepts are anatomical and relate to the position of the lung within the chest and the effect of gravity on that lung. The questions are asked as, what does ventilation perfusion ratio mean? In the upright lung, how does the VQ ratio change? Can you draw a diagram of the lung showing the VQ ratios? Can you graph the distribution of ventilation and blood flow in the upright lung? They also ask, can you describe the normal relationship between ventilation and perfusion in an upright lung? And the prompts here run along the lines of, as already described for gravity. How does gravity affect the ventilation perfusion in the lung? Can you describe conditions that increase VQ mismatch? Can you describe conditions that decrease VQ mismatch? And what tests can be done in clinical practice to demonstrate a VQ mismatch? So the knowledge required here on the surface is pretty simple. If we're talking about a VQ, we're talking about ventilation divided by flow. That's ventilation of a respiratory unit or a lung divided by the flow of blood that traverses that unit or lung. In essence, it is that simple. It comes out with a ratio, and by definition, that ratio gets bigger if we increase our ventilation in proportion to constant flow, or it gets bigger if we decrease our flow in proportion to normal or unchanged ventilation. Likewise, that ratio can get smaller if we decrease ventilation or if we increase flow in relative terms to an area. It's that simple. But what does that mean? If you understand the anatomy here, the concepts are very simple, and the graphs that we'll soon construct are very straightforward. What we're eventually going to talk about is this situation, where we have a calculated ratio, a measure of volume, and we talk about percent volume of the lung. The lung has a total volume, then we're going to talk about a proportion of that so that we can relate both flow and volume on the same axes. We're going to talk about the bottom of the lung and the top of the lung. And that'll be divided into rib numbers, usually, on the graphs that you'll see. And we'll talk about a particular point in non-pathological lungs that exists at about the third rib. And that is the point where the VQ ratio is 1, i.e. flow matches ventilation. Now, what we're going to talk about are these two curves that cross at that point. Two straight lines, relatively straight lines, experimentally straight lines, that describe flow and ventilation. And you'll see that their slopes are different, such that flow changes per rib number more dramatically than does ventilation. What that does is result in a change to the ratio, or the VQ ratio, that looks like this. Of course, a denominator change, a numerator change will make this very steep proportion. Where do these curves come from? Where do these lines come from is the real question that needs answering here, so that we can get our heads around how to answer this properly. And again, we're going to build on the model of a lung that has a perfusion that we've dealt with before. We're going to talk about this lung. This lung has an inlet and a volume. Air goes in here. And it has blood vessels that run through it. The blood vessels exist in several stages of patency. They exist collapsed. They exist sort of collapsed, but not quite. And they exist dilated. Like this. Because what we're dealing with here is a pressure gradient. It's approximately 20 centimetres of water in an upright lung. And if you can imagine, all these blood vessels are joined together and pumped from a single heart that supplies the pressure. The push is uphill, such that there's less pressure here and more pressure here in a static lung that is in the upright position. And so we know that there's changes in resistance in these vessels as we go through. The collapsed vessels offer more resistance. The dilated vessels offer less resistance. Likewise, we can relate, and this is an effect due to gravity on the lung. Likewise, we can relate alveoli that exist in this lung. This lung has weight, and the weight tends to compress the lung, such that structures down here that are filled with air will be compressed. Structures up here will not be compressed as much. This single alveolus will be blown up. This one will be inflated, but not as much. And this one, sitting right at the bottom of the lung, will be collapsed. A remnant of what it was. What that means is that the weight of the lung is pressing down more here than it is here, and substantially more here to collapse this particular alveolus into nothing. So what we can see, the normal state in an upright lung, because of the influence of gravity, is two things. That ventilation travelling in through the trachea into the lung itself will come to this alveolus and won't be able to distend it much more. The component of that ventilation can't go to the top of the lung. There's not much volume left there. It's already got a lot of volume associated with it. So it'll continue on to this portion of the lung, and that ventilation will flow into here and increase the size of that alveolus towards this size. So a fair proportion of the ventilation will end up here, midway down the lung. But even more will travel to this point, where from a zero value of volume, proportionately large increase in volume occurs. So the change of volume here is largest. The change of volume here is in the middle, not quite as large. And the change of volume here is only going to be small, because of the starting positions of each of these alveoli in a normal lung in an upright position because of gravity. So what we can say is the ventilation that goes into this lung, not much of it goes to the top of the lung. Moderate amount of it goes to the middle of the lung. And most of it goes to the bottom of the lung. We'll say that again, but this time we'll graph those words. If we talk about ventilation in an upright lung that has a bottom and a top, most of the ventilation goes to the bottom of the lung. Most of the ventilation goes to the bottom of the lung. A moderate amount of ventilation goes towards the middle of the lung. Towards the middle of the lung. And not much ventilation goes towards the top of the lung. The top of the lung. Those alveoli are already blown up. So ventilation is disproportionate throughout the lung. Most ventilation occurs in the base of the lung. The already collapsed alveoli are able to accept more of the tidal volume, more of the inspiratory volume, and therefore receive more of the ventilation. We'll talk about why that's an advantage in a moment. We also know this because we prone ventilate patients to try and maximise where ventilation can go in a diseased lung. Now, we can use a similar reasoning to talk about flow through this lung. Gravity pulls blood down. So the distension in the lower vessels in the lung mean that most of the flow goes there. I.e., there's more pressure at the bottom down here than there is at the top. Pressure drives flow and the distended vessels allow more blood flow. Whereas the middle portion of the lung, there's a moderate blood flow. And these can be open or closed, but not quite offering too much resistance depending on the circumstance and where in the respiratory cycle you're up to as well. And then we get to the top of the lung, where there's not as much pressure to distend these blood vessels, and in fact they can be collapsed because there isn't enough distending pressure, i.e. not much of the flow goes through these vessels in the top of the lung. Again, we'll relate that to the graph, and I'll say it out loud again while we trace it onto the graph. The bottom part of the lung receives most of the blood flow because it's a higher pressure and distended vessels. The bottom part of the lung receives a higher proportion of blood flow. The middle part of the lung receives a moderate proportion of the blood flow, but not as much as the base. The middle part of the lung receives a moderate proportion, but not as much as at the base. The top part of the lung may receive zero or not much blood flow at all because the blood vessels are collapsed and there is a lesser pressure at the top here. The top part of the lung receives lesser blood flow than everywhere else. So what we've got is a disproportionate blood flow throughout the lung because of gravity. And we've got a disproportionate ventilation throughout the lung because of gravity. Now, the thing to note is that relative terms, we've got a lot of ventilation going to the base of the lung and a lot of flow going to the bottom of the lung. So there's somewhat of a match of ventilation to flow, certainly much more than you see at the top of the lung, whereas a lot of ventilation and not much flow. So they're both increased, the blood flow is increased proportionate to where the ventilation goes in the base of the lung. And we see that by looking at the ratio diagram. The ratio starts out just below 1 until it gets to the point of equal blood flow and ventilation, and then rapidly rises. So the VQ is largely mismatched in the top portion of the lung. And it's easy to see why. There's not much ventilation goes here, but there's less proportionate flow that is here. Not much ventilation in the top portion of the lung, but proportionate less flow goes to the top of the lung. This creates a situation of a very big reserve. If you increase your cardiac output and distend these blood vessels, you can start picking up the ventilation and oxygen that is just sitting around in the top of the lung as well. So evolution has meant that a lung suffers due to gravity these problems of unequal blood flow and ventilation, but you can see the evolutionary advantage as well, providing a reserve and ventilating those portions of the lung that are most perfused. The way to try and rationalise all this is with various pathologies. So we can talk about mechanisms of hypoxia, and this is how it relates. Hypoxia is tissue low oxygen or low PO2 in the tissues. Hypoxemia is closely related, and for argument's sake, we will say very much proportional. Using this reasoning and using the diagram that we used before, which looked like this, of our alveolus on our respiratory membrane, which hosted a blood vessel between here and here across the respiratory surface. We talked about pressure gradients that transferred substances like oxygen from the alveolus into the blood. What we can now talk about is the reasons for hypoxemia in completion. And there's only 4, and essentially there's only 3. 2 are very closely related. The first is going to be alveolar hypoxia. So alveolar hypoxia relates to low oxygen tension in the alveolus. That means there's not a very large reservoir of oxygen to be dragged into the blood and packaged onto the hemoglobin. This can occur for several reasons. If we stop replacement of oxygen by stopping breathing, respiratory arrest, that's the predominant mechanism. The other mechanism that can produce this, even with a patent airway, airway obstruction is another reason. Even with a patent airway, we can increase the partial pressure of other gases inside the alveolus. That displaces oxygen. It means there's not as much room for as much oxygen here. So there's a relative displacement of oxygen out of the alveolus because there is CO2 sitting in here and not as much oxygen can get in, despite it being available. We end up with the alveolus being occupied by carbon dioxide. We can't increase the overall pressure inside of here. We're stuck with atmospheric pressure or close to it. So we can't manipulate the PO2 in here until we get rid of the CO2. So this creates a condition of alveolar hypoxia. Alveolar hypoxia prevents the pressure gradient for oxygen and therefore its movement across the membrane. That's the first way. The second way is diffusion limitation. What we do is we get this membrane and work in a coal mine, looking after birds and smoking all our life. And we end up with interstitial lung disease that thickens this membrane. And this membrane is not as permeable to oxygen. Oxygen is now in the situation where it becomes a diffusion limited gas. And therefore, we can have lots of oxygen in here, 100% oxygen. And we can try to force oxygen down a greater concentration gradient, and we'll be somewhat successful. But we may not get all of this oxygen through to the bloodstream, i.e. there will still be a large pressure gradient for a large PO2 in here and a not so large PO2 here. But by increasing the PO2 in here, we've created an increase in the PO2 here because Fick's law says that diffusion across this membrane, even though the membrane is not as permeable as it once was, is related to the pressure gradient. That's the numerator on Fick's law. So we've been able to improve the PO2 by increasing the FiO2, or the proportion of oxygen sitting in the alveolus, by breathing pure oxygen. But this is an example of diffusion limitation. And that's the second mechanism. You'll note that I just spoke of a pressure gradient for oxygen in here between the alveolus and the arterial blood, i.e. an alveolar to arterial gradient. for oxygen, i.e. an AA gradient. This is what our AA gradient measures. It is one of the ways to work out if there is diffusion limitation. Likewise, I've also spoken of increasing the PO2 in the alveolus, resulting in a small increase in the PO2 in the blood as it comes out from the respiratory surface. So one of the diagnostic ways that we relate increased diffusion resistance or diffusion limitation is that we do get a PO2 response to increasing FiO2. i.e. persons with diffusion limitation benefit from increasing FiO2. They're the ones who go onto oxygen and concentrators. The third mechanism we're going to use these principles to describe, and this is mismatch. So mismatch describes the VQ ratio and areas that are either ventilated but not perfused, and areas that are perfused but not ventilated. And we know of pathologies that cause that. What we end up with is a situation of ventilation but no perfusion, pathologically, called PE, resulting in a very high VQ, or areas of a very low VQ that have normal blood flow but no ventilation, i.e. pneumonia. So we change our mismatch here, we change the VQ ratio, and we can end up with mechanisms of hypoxia. And it occurs through mismatch. Now, there will be some reversibility of mismatch with changing of PO2 and FiO2. The proportion of how that changes is related to the inclusion of the next respiratory unit in here and another membrane that we can recruit. And what is measured as oxygen moving into the system from here, but none moving in from here, and therefore blood being diluted by passing through respiratory units that either ventilate and don't perfuse, or perfuse and don't ventilate. So we're talking about the mixed venous blood here. The partial pressure in mixed venous blood. So essentially what we're talking about is these blood vessels all coming into one, and areas of ventilation or no perfusion are mixing together and forming an average PO2. And we can reverse some of that by changing the composition of the gas. Now, the last mechanism is an extreme form of mismatch. It's called shunt. We sit it out here on its own, thinking of it as an extreme form of mismatch in which we have blood that is bypassing ventilation, i.e. we have no flow. We talk about PE as areas of no flow for ventilation. The extreme form of that is an intracardiac shunt. An intracardiac shunt shifts blood, deoxygenated blood, from the right side of the heart directly to the left, never gets opportunity to become oxygenated by going through the lung, and therefore when it mixes with blood that has gone through the lung, the average PO2 is low. More so, we can start to diagnose this, and we do this in children, trying to work out if they have congenital shunts by increasing the PO2 and producing no change to the mixed venous oxygen saturation. The reason that occurs is that the shunted blood always dilutes an optimally performing lung. Optimally performing lung will load oxygen onto its hemoglobin. It will increase its PO2 to a large value, and then it will always be diluted by deoxygenated blood. That is the hint to a shunt. So persons with shunts do not respond to the increased PO2 when an FiO2 is increased. Persons who have a shunt do not get benefit from oxygen or concentrators. That only contributes to their dissolved oxygen and doesn't contribute to the oxygen content. So shunt stands out as part of mismatch. It's just the extreme form. So we now have the 4 reasons for hypoxemia, and they relate to the last few talks that we've had, and they finish up with mismatch. You'll also be asked about mechanisms of hypoxemia in your exam. STEM, moving on to physiology. She is hypoxic. What does ventilation-perfusion ratio mean? Ventilation-perfusion ratio relates the ventilation of a lung or a respiratory unit to the blood flow that it receives. It relates in certain pathologies, such as PE and pneumonia, in different situations of ventilation-perfusion mismatch, and contributes to oxygenation of the blood. In the upright lung, how does the VQ ratio change? The VQ ratio changes in an upright lung in a predictable manner because of gravity. It's best described in a diagram that relates depth of the lung near the bottom of the lung and the top of the lung with rib number, and the percentage volume of the lung as a proportion. And we can also relate VQ ratio to this x-axis. What we see described is 2 curves relating flow through the lung that is highest at the bottom of the lung because of gravity and lowest at the top of the lung. And we can also relate ventilation with a similar straight line that is highest at the bottom of the lung and lowest at the top of the lung. Where these 2 values cross, because they share a percentage volume axis, is approximately rib 3, and that correlates to the VQ ratio of 1. So what we can do is plot on this curve the VQ ratio, and this is the relationship, noting that it's close to 1 for a lot of the lower part of the lung and rapidly becomes very high near the top of the lung. And that's the question.